you want to be healthier, yet you just don't know what to do? All these shows telling you this and that, but nothing seems to work. Well, listen close. Golden State Media Concepts has got something great for you. The Health and Wellness Podcast dedicated to workout trends, healthy eating habits, diet, and everything about healthy living. Join us in our banters as we help you not just live life to the fullest, but live it to the healthiest.
Thank you for tuning in to the GSMC Health and Wellness Podcast, brought to you by the GSMC Podcast Network. I'm your host, Alex. There is a lot going on in the U.S. this week, y'all. We have early voting ended in many states on Saturday, I believe, on Halloween specifically. That's the day I voted, so if you haven't voted yet, get on out there and exercise your right to have your voice heard. But we also have the election coming up tomorrow, so the actual election date for us is Tuesday. So if you haven't gone out yet, you can go ahead and go. There is still time, and remember, if you're at the polls at 7 p.m. or so, whenever it's supposed to end in your area, and if you haven't voted yet, you can still stay in line and vote. As long as you're already in line by that time, you are all set. It may initially seem random that I bring up voting at the beginning of this health and wellness podcast, but it's super relevant for your emotional wellness, your social wellness, and even your physical and mental wellness. In my personal opinion. It could also affect your financial wellness and your intellectual wellness in regards to having access to certain realms of knowledge. And that's particularly relevant this week as open enrollment has recently begun for the health insurance marketplace. So that's when you go online and you figure out what type of health insurance you want for the next year. So today, I want to talk about health insurance because, let's face it, it's a little mind-boggling unless you are specifically working in the realms of healthcare. I personally did not know a ton about health insurance beforehand. I always read through my own particular options whenever I'm offered it through work, etc., but I don't do a lot of comparisons between them typically. So today, if you are as confused as I've been about these things, stick with me while we demystify health insurance in health and wellness. First, we're going to talk about the history of health insurance in the US, so how it came into being and when and how that's changed over the years. We're also going to talk about differences in ObamaCare versus TrumpCare and whether or not those pre-existing conditions would still be covered. We're also going to talk about open enrollment and the marketplace to help you guys make these decisions for what's best for you. And then we're going to talk about the best health insurance options for you in our final segment. So first up, let's talk about the history of health insurance in the US. I know that normally I start these episodes off with really just definitions of what we're talking about, but health insurance is more of a holistic perspective, just like healthcare. So it's not enough to just define what it is, but I want to talk about healthcare and health insurance in the United States within the context of different decades. We are in 2020 now, but health insurance in the United States is very much a 20th century phenomenon. It's about as long as it's been around. So we're going to talk about developments in medical technology, changes with hospitals and physicians, and how government policy has resulted in the development of Medicare and Medicaid in particular over the years. So first up, Health insurance and sickness insurance are two different things. I know we often say that healthcare today is really sick care, or health insurance is really sick insurance, but there used to be a real thing called sickness insurance back in 1900 to 1920. So before 1920, a lot of the medical technology that we had meant that you couldn't do much for most of your patients, and there were a lot of house calls. To contextualize what was going on in the U.S. at that time, think Dr. Quinn Medicine Woman. So that's set in about 1867. So about 30 years after Dr. Quinn and about 14 years before World War I is when we're talking about this occurring. So there was a lot of changes and industrialization that happened in that time, but it's still a relatively small window. So back then, a lot of people were treated in their homes. If you were Dr. Quinn, you would give people a lot of morphine. You got a cough? Morphine. You have anything else wrong with you? Morphine. Is it pain related? Is it not pain related? You're gonna get the morphine. At least that is the satirical take of Dr. Quinn, Morphine Woman, if you guys have not seen that video. But it's pretty true to the TV show. So we had a lot of pioneering advances early on in medicine, but we didn't really see even hospitals as they are now as being these concentrated areas where people go for their health until the turn of the century, because then we had antiseptic methods. So surgery was still performed largely in people's homes until the 1920s. Yeah, someone would come into your home and they would perform surgery on you, and then you would be left to convalesce in your own bed. So that part sounds pretty cool. Then you don't have to pay for staying in a hospital or any of that stuff, but it might not necessarily have been as sanitary. Did they bring their own tables? I'm not sure. But that was truly persisting as being normal until the 1920s. But let's walk it back a little bit. So there were some important milestones along the way that allowed us to get there. And a lot of that was involved with using microscopes to understand bacteria and our immune system and how to protect our immune system against these bacteria with the use of antiseptics and such. And this was really jettisoned into a crazy quick trajectory of modern medical developments by Dr. Semmelweis, in my opinion. Dr. Ignaz Semmelweis was a 19th century Hungarian doctor who noticed that a lot of women were dying in the Vienna hospital he worked at when the doctors came from working in the morgue to directly delivering the babies in the maternity ward without washing their hands. So he put two and two together and saw that, if people started washing their hands before they went to deliver a baby, then the mothers didn't tend to die from these septic issues. So he really changed the entire trajectory of how many people were dying in routine situations like childcare, something that non-human animals do on their own just fine. But we were accidentally killing women by not washing our hands. And at first they thought that he was nuts. People argued with him and they were not really coming around to it. He was like, you can't just go from an autopsy to a delivery without washing your hands. They didn't even use gloves back then either. Gloves weren't commonly used in hospitals or surgeries until the late 19th century. So people didn't really understand this until Dr. Semmelweis noticed that chloride solutions would get rid of the odor of objects. And he's like, okay, if it gets rid of odor, maybe it's getting rid of something else that we can't see. And so he demanded that everyone in his department wash their hands. And essentially, he was using a chloride solution, like bleach. He's just saying, hey, bleach kills these things. Let's go ahead and wash our hands. So he's like, maybe if it kills the smell, it'll also kill any bacteria or anything harmful. And Dr. Semmelweis is one of my all-time favorite healthcare historical figures. I'd even go so far as to say one of my favorite scientific historical figures. We learned about him in microbiology class, and I will always appreciate him putting this pattern together in the realm of the unseen. You can't see odor, you can't see bacteria, but the man still noticed this pattern and changed the world for humans in general and women in specific, just from noticing that difference between the autopsies in the maternity ward and daring to do something about it, even when everyone else told him that he was wrong. So soon after this, within about 3 years or so, from 1850 to 1870, there were a lot of other scientists like Louis Pasteur who were studying bacteriology and immunology and also antisepsis, making sure that antiseptics were available to keep people from getting sick from these bacteria. And so that happened for about a 20-year period following Dr. Semmelweis discovering this in Vienna. Then they started identifying different types of infectious agents between 1870 and 1910. And that includes things from the spirochete family like syphilis to typhus and pneumococcus that causes pneumonia and also malaria. They developed diphtheria antitoxins as well. And as a result, a lot of fatalities related to surgeries also fell. So now we have fewer people dying during childbirth, and we also have fewer people dying during surgery, just because we now understand the nature of bacteria and its relation to the immune system and the fact that we can mediate that with things like Clorox. So then in 1887, SSK von Basch invented an instrument to measure blood pressure. In 1895, one of my other favorite scientists, Wilhelm Röntgen, I might be pronouncing that wrong because I learned his name while reading it, but he developed X-rays. They were originally called Röntgen rays, Roentgen, but now they're what we call X-rays. And then in 1910, a drug treatment called Salvarsan was the first drug treatment to destroy diseases without injuring the patient. And that was a treatment for syphilis. Between 1920 and 1946, we also saw insulin being isolated, sulfa drugs were developed, and other large-scale productions of synthetic penicillin were really beginning. So around 1946, this is after World War II, is when we started large-scale production of synthetic penicillin. And then in 1955, Jonas Salk announced the development of a vaccine for a disease called polio. And my mama had polio, so this was really not that long ago. It was 1955. Now, I know that when we think of now being 2020, 1955 feels a long time ago, but I'm 30, and my parents' were alive during that time, and they're still alive now. This is also before the Civil Rights Movement, so this is 10 years before Malcolm X was assassinated in 1965 that we developed a vaccine for polio. So after World War II, but before Malcolm X was assassinated. Now, I tell you all of that so that I can explain the medical expenditures in that time as well. So before 1920, there wasn't a lot that could be done for people who were sick. A doctor could come to your house, they could maybe give you surgery at your home, but we didn't really have X-rays being widely available. We still didn't have a vaccine for polio, and we also didn't have large-scale production of penicillin, really. We didn't even know that sulfa drugs, which are antibiotics, were available to be helping us at that time either. It was crazy how little we could do back then with that era's modern medicine, especially compared to now. But because of that, most people didn't pay much to go to the doctor. You only called the doctor when you were very sick, and then they came to your home, and there's not much more they could do other than give you some morphine / some cough syrup. And then in 1918, the Bureau of Labor Statistics surveyed 211 families who lived in Columbus, Ohio. And they found that only 7.6 of their average annual medical expenditures were used to pay for hospital care. So they were spending less than 8% of their annual income on any type of hospital care. And they found that also the primary cost associated with being sick in the U.S. at that time wasn't actually the cost of medical care, but instead the fact that people who were sick couldn't work, and so therefore they didn't get paid. So it's less to do with how much medicine cost back then and more so to do with the fact that people weren't making enough money to really get by on and couldn't afford to be out of work sick. So in some ways, it's not all that different for many people today. Then in 1919, the following year, the state of Illinois performed a study and found that lost wages due to sickness were actually 4 times larger than the medical expenditures that were required to treat the illness. So because of that, most people didn't feel that they needed health insurance. Instead, back then, people would purchase something called sickness insurance, which is a lot like disability insurance today. And the purpose wasn't to put money into an account until you got sick so you could go to the doctor, but rather that if you did get sick, you had some money that would be available to be dispersed to you so that you effectively wouldn't be missing your paychecks even if you were out of work sick. So it wasn't even meant to pay for medical expenditures. It was for cost of living expenses. Now that has a whole separate area of problems related to capitalism and all that, and we'll get into that perhaps in an episode on financial wellness. But for now, I want to stick particularly just to health insurance. We're going to go on a quick break, and when we come back, we are going to talk about how this sickness insurance developed into health insurance. And we'll also talk about the differences between TrumpCare and ObamaCare today. Stay tuned.
Are you looking to learn more about the latest trends from the fitness world? Are you confused by all of the different trends that are out there? The GSMC Fitness Podcast is the place for you. The GSMC Fitness Podcast is the place to come for people of all skill and interest levels. Join us as we explore the latest trends in the fitness world. Does that new exercise really work? Should I try yoga? Whatever your question, chances are good you'll find an answer on the GSMC Fitness Podcast.
Welcome back. Before the break, we were talking about the developments of modern medicine in the United States and also some developments that occurred in Europe between 1845 and roughly the 1920s. So during that time, we went from doctors mostly performing surgery in your homes and people not washing their hands between autopsies and going to the maternity ward to deliver babies, to having vaccines for polio by 1955 and being able to measure blood pressure, x-rays being developed, and getting the first drug treatments that could kill a disease without also harming the patient, which is something that we take for granted today. In fact, we take a lot of these for granted. We have blood pressure cuffs at home. You can get them pretty cheap at a lot of stores out there. I bought mine online from Amazon because my cholesterol was too high. My blood pressure was a little high. One day, my doctor wanted it checked, but it turns out it was just nerves, and I was okay. So that's the good news. But that's not something that would have been possible for someone to do back in the 1800s. And indeed, even in the early 1900s, it would have been more expensive. So as a result of that, a lot of people were paying more money for something called sickness insurance, which was meant to replace your wages if you had to miss work, instead of buying health care, which is meant to cover annual medical costs. So, this was very different, and sickness insurance started as being something that was to address the lack of money that people had. Like, it was really bad if you got sick and you needed to be out of work. And that is still a stark reality for many Americans today. And my point in mentioning the socioeconomic component is that sickness care was very much a socioeconomic insurance. It wasn't meant to address actual sickness or health. It couldn't actually have anything to do with making you better or not. It just made sure that you didn't lose money. You didn't lose your paycheck. It effectively made it as though the person were a salaried employee rather than an hourly one. And that's really all it was. It was an economic measure, not a health measure. So we've gotten a little bit off the track from that today, but it's still economically based. Remember that back in 1920, most people had very low medical expenditures, and in Ohio, only 7.6% of the average annual medical expenditures paid for by families in Ohio were for hospital care. Less than 8% were for hospital care. Think about how much you spend today on health insurance instead. I want you to also think about the difference between what percentage of the time you end up having to go to the hospital for something that you can't deal with at home. And think about how much you would lose per day in wages if you had to be out for, say you have the flu and you get it right around the weekend because that's when your immune system is finally able to go, whew, don't have to stay strong anymore because I'm so stressed. I can relax now. And then the illness it's been holding at bay kind of wreaks havoc on your body. That's why I always get sick on your days off. So then maybe you only need Monday, Tuesday, and Wednesday out of work. Like you're really sick, but you've gotten through the worst of it. You don't have a fever anymore. You're not contagious, and you're going to go back. So however much you make an hour, and if you're salaried, go ahead and calculate that back, and then see how much that would be for those 3 days. So I calculated that based on an assumed hourly rate of $15 per hour. So assuming that you're working 5 8-hour shifts per week, that would be 15 by 8 by 3. So $15 an hour by 8 hours by 3 days. And so that number that I got was 360. And then I multiplied that by 12 to see the annual cost, and that's $4,320. So I compared that against the average amount paid in insurance for people in the US today. So that $4,320 was the amount of lost wages if you were sick for 3 days, sick and out of work for 3 days each month all year. I don't know about you, but I hardly ever called in sick. So that is a crazy overestimate for me. However, if you look at the average cost of insurance for an individual in the US right now, that's $456 a month, and times 12 is $5,472. If you look at it per family, that is $1,152 average paid per family for insurance in the US, and you multiply that by 12 and you get $13,824. So that's how much people are paying for this insurance each year. And if you think about that in the context of this $15 an hour analogy, that would make it somebody making about $31,200 per year. Now that's before taxes and everything else. So that money is coming out of there. Now, granted, there's about a $90 difference between that $15 an hour assumption that I made and also the amount that people are paying in insurance each year for individuals, $456. However, that's the average in there. So there's a wide range actually in America of the prices in health insurance packages. So this is more or less roughly mathematically okay for our purposes. We're assuming someone on the timeline within that normal distribution, right? So roughly, I would say people are putting a lot of money into their health insurance. In Ohio, remember, it was about 7.6% of their annual expenditures were related to hospital stays or medical costs. So now let's divide that $5,472 that are spent annually for the average individual getting healthcare in the U.S. by that $15 an hour wage, which was $31,200. That is 17.5% of their annual money is being spent on health insurance. Now remember, health insurance also doesn't even cover everything, depending on the type of insurance that you have, so you may still have bills on top of that. So that is an increase of roughly about 10% since the 1920s. So we are at 17.5% now. We were at 7.6% on medical costs back then, but that was their total medical costs. That wasn't health insurance alone or paying for what you're not using. It was just when they were sick, they would go to the doctor, and that is how much they would spend annually, was less than 8%. So now we are spending 18% each year of our annual income, if you make about $15 an hour, on health insurance. And that has nothing to do with necessarily how much is covered. You may have like one x-ray covered, but say you're really clumsy and you break 2 bones in a year. Well, that's not great. That doesn't mean that dental insurance is also included, or vision insurance, or if you lose a pair of glasses and you've already gotten some that year within that insurance period, that they're not covered for the replacement too. So it can be really, really expensive after a while. But these are big differences that have happened since about 1920. So literally in the past 100 years, now that we're in 2020, that's how much it's changed in cost and what it really addresses. So health insurance started as sickness insurance, and that just covered really the wages that you would miss if you were sick. And then afterwards, it has become banking money in case you get sick so that you can cover the medical costs. It doesn't even address the money that you miss while you're out of work. But we've had a lot of medical developments over the years too, and that may also be associated with it. So that's a long time in history, right? So we went from not even being able to see bacteria and washing our hands to now having the healthcare industry as we see it today. But it was kind of rocky along the way too. So back in the 1920s, there was low demand for health insurance. We didn't really need it. So why would we even bother? And at the time, people were really unwilling to offer private health insurance policies. So you had health insurance offered through companies, but they didn't want to offer private ones. So these commercial insurance companies thought that health was not really an insurable commodity because there was a high potential for hazards along the way. So they felt that it was not really fiscally reasonable. And they thought that they also didn't have enough information to really calculate the risk and the appropriate amount of premiums required for folks. So people who were in poor health might say that they're healthy and then sign up for health insurance. That's the pre-existing condition clause. And for a lot of people, that makes a ton of sense. Why would you pay for this insurance if it's just going to take money out and you might not ever even use it that year? why don't you just wait and then pay for it when you do get sick? There are many different perspectives in this realm, and regardless of where I stand, I do think it's important to consider all of them so that we can understand everyone else's point of view. Also, a lot of times, people have insurance already, but they have basic insurance, the kind that covers, your visit to the doctor for a well check, or maybe just, one for emergencies. There's all kinds of different types of insurance. And so maybe you had emergency insurance, but it turns out you get diagnosed with something that's a chronic illness, like cancer or kidney disease, and you require dialysis. And so it's going to be a chronic, ongoing treatment rather than this emergency type care that you had prepared for. There are many different reasons why people might make these choices, socioeconomically and so on. And that's largely what makes the pre-existing conditions clause such a big deal to people on both sides of the aisle. And by the aisle, I mean Democratically and Republicans, roughly, conservatives and liberals. But this is also something that happened in Europe around the same time, but it was very different. So people in 1920 or about that time didn't feel like actual health insurance was necessary. They thought that sickness insurance made a lot more sense, because if you're only spending 8% of your annual income on your hospital visits, then it would make more sense to just make sure you had your money in your pocket so that you could keep that annual salary amount. So in Europe around 1920 or by 1920, most European nations had adopted some sort of compulsory nationalized health insurance. So like universal health care in their countries. But there were proposals sponsored in the US as well to do that, but they were never enacted. Those health insurance compulsory components were never enacted here. And that's because partly popular support for that legislation was low, because folks were like, we don't need it. Why would we do that? And then a lot of doctors also opposed that because they feared that the government intervention would limit the amount of fees that doctors could charge. So they could charge an arm and a leg back then. There was no regulation as to really how much the doctors could charge. And then pharmacists also didn't like it because it provided prescription drugs. And they thought that might put them out of business. So a lot of commercial insurance firms didn't offer health insurance during that time. But a large part of their business was offering burial insurance to pay for funeral costs. So they were benefiting either way. The insurance companies are really the ones who come out on top no matter what. So under that new proposed legislation, the commercial firms could be excluded from offering burial insurance. So as a result of that, they opposed that legislation, and they were afraid that would open the doors towards government intervention in the insurance business. So really this comes back around to socioeconomic issues, where doctors and pharmacists and insurance companies were all worried about who could come out on top in making this money. And health insurance companies or insurance companies were saying, hey, you think we're going to get more from offering health insurance or from offering burial insurance? Literally profiting off of life and death. And in a very macabre way. But like many problems, you can just follow the money as to how that developed. And between 1920 and 1930, the price of medical care rose significantly. We're going to go on a quick break, and when we come back, we're going to talk about those increases in prices and how we got to ObamaCare and TrumpCare today. Stay tuned.
Tired of searching the vast jungle of podcasts? Now listen close and hear this out. There's a podcast network that covers just about everything that you've been searching. Hey! The Golden State Media Concepts Podcast Network is here. Nothing less than a podcast bliss with endless hours of podcast coverage. From news, sports, music, fashion, cooking, entertainment, fantasy, football, and so much more. So stop lurking around and go straight out to the Golden State Media Concepts Podcast Network. Guaranteed to fill that podcast itch. Whatever it may be. Visit us at www.gsmcpodcast.com. Follow us on Facebook and Twitter, and download us on iTunes, SoundCloud, and Google Play.
Welcome back. Before the break, we were talking about changes in the healthcare industry regarding insurance policies in Europe and getting universal healthcare up to about 1920, and then the United States rejecting it, mostly because pharmacists and physicians and insurance companies all feared that they wouldn't make as much money if they were to have compulsory health care across the entire United States. So universal health care is what they were talking about, and people didn't want to pay for it. Rather, a lot of regular folks didn't think that they needed it, and the providers felt they weren't going to be able to charge so much money if the government interfered with it. So we ended up not getting that. And then between 1920 to 1930, the price of medical care increased. And there were a lot of changes that happened to cause that. And that meant that a lot of folks were getting less acute illness treatment in their homes and more of it in hospitals. And those changes resulted in medical care continuing to rise in price, while medical care also increased in regards to how frequently people were using it. Now we had things like antibiotics and such that could be administered, so folks were able to go to the doctor more. It made more sense to go to the doctor then. So then we had this increase in the cost of supplying medical care, and you also had a resulting increase in standards of quality for physicians and for hospitals. Now that we knew you had to wash your hands and we had antiseptics, they were required to be used. And it made more sense in some ways to be able to keep a sterile environment in a hospital rather than trying to apply antiseptic to each person's home before doing surgery in their own home. So, as the population also shifted in the United States from being largely rural to being more urban, families started living in smaller homes. So we were living closer in proximity to each other, both within our homes and between our homes. So we were having the rise of more apartment buildings and such. And that gave us less room to take care of sick family members. So they say that with COVID, if someone in your family falls ill, the rest of the family can still stay safe if you take the appropriate antiseptic measures, and you also make sure that that person stays in their own area and uses their own bathroom and stuff. That would have been a lot easier prior to the 1900s, when the homes were more expansive and spread further apart. So we can still do that today, but this change started about 100 years ago, and it's made it a little bit more difficult than it might otherwise have been. And that's a real simplification of it. There are a lot of trade-offs here, don't get me wrong. But these advances in medical technology, along with people starting to really accept that medicine was more of a science, it wasn't just snake oil salesmen or peddlers coming through the towns and promising products that didn't deliver. It was growing as a science. We knew about bacteria now. We'd made a lot of the unseen seeable with microscopes and everything, and started standardizing more of our science and our research as it related to medicine. It wasn't just people taking corpses or cadavers and drawing pictures of them to discover anatomy anymore. We were looking at the interplay of structure and function, anatomy and physiology, and how we also related to different life forms like bacteria and how to fight them. So it was becoming more of a body of knowledge rather than one of conjecture. We weren't dealing with people treating humors anymore. And that helped people believe more in the value of medicine and the effectiveness of it and its efficacy, really. So it began building by somewhere in the 1920s that these people who could be patients were strongly influenced as to whether or not to seek treatment and medical care, not only by the hope of being healed, but because they were seeing a new kind of medicine, a medicine that was more precise. It was efficacious. It did exactly what it was supposed to do. And it was scientific. It was reliable and repeatable in the results. So this really began to get more attention, and it changed in regards to making sure people needed to be licensed and have standards of care among different practitioners of medicine. And that also led to an increase in the cost of providing medical care. So it's like how you have to go and pay for your driver's license, and you also have to take the written test and everything beforehand, and how that costs so much money. And if you lose your license, you have to pay to get a replacement and do a lot of that stuff over again. Or if you have to renew it, you still have to pay for another one. And you're not just charged for that little piece of plastic, but also for all the hoops that you have to jump through and all of the people along the way who have to hold those hoops on behalf of the government. So that is not all that different from what a lot of other practitioners have to do. So we can view ourselves as practitioners of driving in general. If you have a license, you are practicing driving. But we also have people who do lawyer work. They work in law. They work in salons and the hair care industry. The beauty industry has its own set of practitioner rules and also licensures and their standards of staying up to date. So they're getting checked every year for their health and safety measures and given a grade and things like that. So that means that these doctors who were going through the similar thing at the time were also being charged more to get their license and to maintain their license. So they were starting to charge more because they were having to pay more. And that happens in a lot of different fields. And once you have the standards of care, now you need health inspectors to come through and check restaurants as well as these doctors' offices for those standards of care and cleanliness. So you have another person you're having to pay. And then that makes it also harder to do a home visit. You can't do the surgery there if the home doesn't meet the standard of care. And once that standard of care is set at being antiseptic, it's nigh impossible for you to make those changes, right? It makes more sense to have an environment you can control like a hospital and keep the antiseptic all clean. And now the health inspector only has to go to one hospital rather than to everyone's homes. I don't think a health inspector audit would potentially really be a thing, but who knows? History is always taking us by surprise while we are living it. It's only apparent in retrospect. But I think of this kind of as being like an IRS audit, but with health inspectors, where they just kind of show up and they're like, hey, we're going to inspect your home now. You were chosen randomly out of a pool of 3,000 people who had surgery in their homes in your area last year. So we're going to go ahead and check and make sure the doctors made sure this area was antiseptically sound. That sounds super invasive. And my point is that there are pros and cons on both sides of it. So after this, we also began to see an improvement in physician quality. So all of these changes weren't for naught. After they developed standards of care, even though it costs more money to regulate and maintain those, they did see the American Medical Association bring about a lot of improvements. And so the AMA started being very largely influential in the 1910s with all of these changes. In 1904, they formed the Council on Medical Education to sit down and create standardized requirements for getting a medical license. And they invited different people to come and evaluate the status of the medical education. So they had some highly critical reports on it, and people found that there were a lot of changes that had happened in modern medicine in the past 50 years even, that would make it a lot easier for more people to survive, that the medical industry could do a lot better if they would make sure that hand washing was compulsory, that it was absolutely required, and doing things like making sure people were washing with antiseptics in a certain way, and also leaving them on the surfaces long enough, and wearing gloves, and the little things that we take for granted. The things that aren't sexy enough to be on shows like ER or Grey's Anatomy. No one sits there and films the tools being cleansed in the autoclave. No one sits around and just shows you everyone restocking the OR and cleaning up all of the materials. And true, those things may be less interesting or sexy, but it also helps continue to promote the American people's ability to just take that for granted. We don't think about it that much unless you're someone who directly works with PPE for health-related reasons. You really probably don't think about it all that much, about all the stocking and background work that goes into it. But we've only had those really mundane things for about 100 years. I just think that part's really cool, that we've come such a long way in such a short period of time. But it's part of just medical development. So standards that were created by Flexner and others helped us to make sure people were well trained, regardless of which school they went to become a doctor, and that they were all able to pass tests that had a certain amount of knowledge required that was standardized across these states. So after that Flexner report was published, the U.S. went from having 131 medical schools to only 95 in a 5-year period. By the time we got to 1922, so after the end of World War II by about 4 years, so by that time, we had gotten down to 81 medical schools. So 50 of the medical schools that had been open before were found not to meet the standards of the Flexner report in what we could truly accomplish. So we had to get rid of 50 medical schools. That's out of 131. So that's a huge amount of people who were being taught how to perform medicine by people who weren't really meeting the standards requirements for it. Yikes. So that changed how this happened to come about a lot, but that also meant that now there were only 81 schools that were available to teach this, and so more students became concentrated at those individual schools. And these increased requirements for the education and the licensure for the specific physicians who were graduating, and now also for the medical schools to be accredited and recognized as meeting those standards, meant that there were now fewer physicians available, and that also put pressure on the cost of physician services. So it's all back to supply and demand. But then we started seeing more standardization and accreditation in 1913, and these folks who were to become surgeons had to meet these really strict standards, and it was part of the American College of Surgeons, which was founded that year. So for a hospital to get that ACS accreditation, it had to meet some standards relating to their staff, how they kept their records, and also the different facilities available for diagnostics and therapeutics. And only 13% of 692 large hospitals examined in 1918 were approved. Between 1918 and 1932, though, a lot of them made changes, and 93% of the 1,600 hospitals examined met the ACS requirement in 1932. So once the standards were set and people had, roughly about 14 years to make these changes, people rose to the challenge and decided to meet those strict standards. So in 14 years, a lot changed. And even though people had fought it initially, they were seeing that there were merits to it. In those 14 years, there were a lot of statistically significant outcomes to show people that scientifically, yes, this was valuable. As this demand for hospital care increased due to various reasons, we see that there's a new payment system developing. And about the end of 1920, we would see the precursor to Blue Cross and Blue Shield founded. So it was founded by a group of teachers in Dallas, and they made a contract with the Baylor University Hospital to provide 21 days of hospitalization for a fixed payment of $6. And then that plan developed as a way to make sure that people paid their bills. So it was a way to make sure that the hospitals could collect their money. And then we see that there was an official connected with the plan who compared the hospital bills to cosmetics. And they said that the nation's cosmetic bill was more than the nation's hospital bill, but that we spend $1 or so at a time for cosmetics, and that means we don't notice the high cost. And at the same time, the counter clerk who works there can be paid $50 or $60 or $1 a month, and it would take about 20 years to set aside a large hospital bill. So they're saying, hey, we're making more money in beauty products than we are with healthcare because people only go when they really have to go and when something's bad. So they're having to pay that as a lump sum all at once. But people buy makeup on, a daily, a weekly, a monthly basis. And so it's only a little bit at a time. And so they're not noticing. So maybe we can find a way to make it to where people don't notice how much they're spending. And that way we can make more money. So then these prepaid hospital service plans started growing, especially over the course of the Great Depression. And then this prepaid hospital care was working out pretty well for both sides, both the subscribers and the hospitals in the early 1930s. But consumers and hospitals started suffering from not making as much money because, of course, the Great Depression. So those prepaid plans allowed customers or patients to be able to affordably pay for hospital care. And it also made the hospital more likely to earn income in a time where they weren't really going to normally make money. With the Great Depression, folks were not going to go to the doctor as much, but if they could put aside that little bit of money at a time, then they would be able to really afford it. Sort of like the old Kmart layaway system for your whatever you want to buy at Kmart, clothes, etc. Health insurance is like layaway for healthcare services. So you're paying just this little bit at a time and you don't notice it as much. And so hospitals were still getting money when people normally wouldn't have been going to the doctor because people were able to pay that little bit at a time. But only 62% of the beds in private hospitals were occupied, compared to 89% of the beds in public hospitals that accepted charity care. So they were really happy with how much money they were getting, as long as the amount of money that they had allowed the hospitals to keep operating. But when the funds started disappearing, it made it harder for hospitals to afford to stay open. That in turn resulted in really the hospitals offering specific hospital coverage and trying to reduce the competition between different hospitals. And those plans where you would buy insurance related to a specific hospital to get care at that place, not based on the type of illness you had, but rather the hospital itself and the other hospitals within that community. So like a group of hospitals would band together and be like, hey, you can come and get treatment at our locations for this much money. And that's what Blue Cross was. So insurance was really born. And over the years, Blue Cross and Blue Shield developed separately. And there wasn't much coordination between them at all. At the same time, doctors were worried that having a third-party system of payment would lower their incomes by messing with their doctor-patient relationship and not allowing the doctors to charge people as they saw fit. So doctors started creating their own plans, so directly going to the patients, and those became known as Blue Shield in 1946. So you had insurance companies offering prepaid plans, and you also had doctors offering these prepaid plans, one called Blue Cross and one called Blue Shield. Eventually, these companies merged together and became Blue Cross and Blue Shield. These changes continued to develop with more insurance companies and physician prepaid plans being available up through the 1960s with the establishment of Medicare and Medicaid. And now those are two of the major healthcare plans in the United States, in addition to the offerings on the marketplace, what we refer to as being ObamaCare. We're going to go on a quick break, and when we come back, we are going to talk about the difference between ObamaCare and TrumpCare and how to go about getting these different insurance policies that might be best for you in the marketplace. Stay tuned.
The GSMC Life and Happiness Podcast takes you on a journey of exploration. We'll discuss tried and true methods alongside the latest trends of how to best live your life to its fullest and happiest. From psychology to meditation, science to self-help books, the GSMC Life and Happiness Podcast will help you to discover what makes you happy and how you can live life being the best you possible. Download the GSMC Life and Happiness Podcast on iTunes, Stitcher, SoundCloud, Google Play, or anywhere you find podcasts. Just type GSMC in the search bar.
Welcome back. Before the break, we were talking about how Blue Cross and Blue Shield came about and how we eventually developed Medicare and Medicaid in the United States alongside many different health insurance plans, including what we are now going to discuss, which is TrumpCare and ObamaCare. Then we're going to talk about the best options for you for insurance, and we will also discuss how to find those in the marketplace. So, first up, what are TrumpCare and ObamaCare? It's important that we know those differences when we're looking for health insurance coverage, and when we're making decisions for voting, not just for president, but also for our local people. So, local politicians are the ones who become your regional politicians, and then the national politicians. So it's important to pay attention to that as we go along too. And hopefully, whether you're looking for this information for voting or for just making financial and healthcare decisions, this will help you either way. So first up, what is ObamaCare? ObamaCare is actually the nickname for the ACA, the Affordable Care Act. And Obama signed that into law in 2010, 2 years after his beginning of his first term. And so it's not a healthcare plan in and of itself. Obamacare is kind of found to be synonymous with healthcare because it has care in it. So we think about it like Medicare or Medicaid, but it's not actually an insurance plan. Rather, it's an act. So it's like a set of laws that means that healthcare systems in the U.S. could not deny a person insurance coverage or charge them more for their insurance plan if they had a pre-existing condition like heart problems or organ failure or cancer, things like that. Before that point, insurance companies could do that. So this was only 10 years ago. Before that point, if you had cancer and you wanted to get insurance, they could outright deny it to you or even charge you a crazy amount of money for it. They didn't have to charge everyone the same amount. They could charge it based on your pre-existing condition. So that act required insurance companies to also cover basic services. So like preventive care, like your women's well care, when women go once a year to go and get checked. And then it also required them to cover some types of prescription medications. It also gave people who had low income some subsidies to help them afford their healthcare coverage. So it just gives you money to go, hey, here's that boost you need. Go ahead and get this healthcare with it. Now, it was contentious among some people because it did also state that everyone had to have a healthcare plan unless they qualified for hardship or some other type of exemption. So a lot of people didn't like that they were required to have healthcare even if they didn't want to or they were penalized. The ACA also helped reduce the amount paid by individual patients or families for care that the hospital was uncompensated for. So it made sure that the families weren't having to pay as much to the healthcare system for their care. TrumpCare, on the other hand, is the nickname for the American Health Care Act, so the AHCA. And this was a plan that was created by Republicans in the House of Representatives to replace the ACA. So the AHCA, TrumpCare, was voted on and it was passed in the House on May 4th, 2017. And for that to become a law in the American political system, that means that the Senate had to then vote on the bill and pass it with a majority vote. And then that meant the bill could go to the president's desk to be signed into law. So the AHCA has not become a law in 2020. So it passed the House, it passed Congress, but it didn't really pass the Senate. So Trump was not able to sign that into law. But he did sign an executive order this year declaring that it was U.S. policy to protect people with pre-existing conditions. So that was already in place through the ACA, through ObamaCare, but he did make that line in the sand for it with an executive order as well. I'm not sure if that further cements it as being true or being something that has to stay in place, but regardless, that happened. So what are the differences between these two? So with ObamaCare, you have a federal tax penalty if you don't enroll in an insurance plan, but with TrumpCare, you do not. They both have subsidies to help low-income families afford insurance. The plans are required to offer benefits for preventive care under ObamaCare, but they are not required to for TrumpCare if the state receives a waiver from the federal government. They can both have the kids who are adults remain on your parents' plan until age 26, so nothing changes there, college students. There is also designated open enrollment periods to purchase a plan for both. They both have special enrollment periods based on life events like losing your job, things like that. And in the case of government agencies determining mandatory benefits, federal agencies do that for ObamaCare, but federal agencies or states that are granted a waiver can do that under TrumpCare, which is important to some people when you're talking about states' rights. Both have caps on profit-taking through medical loss ratio rules, but when it comes to the state authority to manage Medicaid, TrumpCare allows that, but ObamaCare does not. That is relied on the federal government to do that. The federal government manages Medicaid, whereas TrumpCare wants to allow certain states to be granted a waiver to do that themselves, should they so choose. Now that we've covered the differences between these two acts, TrumpCare and ObamaCare, I want to talk about using the marketplace. So some people in the past have not wanted to use the marketplace because they think that it is Obamacare, that they think that it is an insurance plan offered by the government and signed into law by Obama, and that they don't want his health insurance plan. But remember, Obamacare, or the Affordable Care Act, is just a set of rules to govern how insurance companies are able to offer insurance plans to the people, and to make sure that people aren't denied coverage because they have a pre-existing condition. Things like that. So right now it's open enrollment. And so that means that there is a set amount of time from November 1st, roughly, through December 15th. And those are the specific dates for this year to sign up for insurance for 2021. So that means anyone can enroll for any reason. This is not a special enrollment. Special enrollments means you lost your job or you've lost your insurance for some reason, and now you need to get more insurance. So that is a lot different than this open enrollment. Anybody, if you just don't like your insurance, you can swap to another one. That is the beauty of open enrollment. And to do that, you can go to healthcare.gov. You can look at your different options in the marketplace. It might ask you a few questions related to the people in your household and how much money your household collectively makes per year. And that's so they can find you the right amount of money to pay for these. So if you are low income, then it can help you find the subsidies that you need to make up that rest of that money, so that the government is effectively paying for the amount of money that you would need to offset being able to afford it. So they will help you estimate your income on the application. You can also see if there are variables that help you save on health insurance. So it's going to ask you how many people are in your household and what state you live in, and that's going to give you different offerings based on that. And then you'll select your income range. And that option list is below $17,608, 17.6K to 31.9K, so that up to $15 an hour bracket. Then the option is between that $15 an hour, that $31,900 to $51,000 per year, and then above $51,000. So you'll submit that, and it will help you estimate your expected household income. And in order to do that, you can just get out your taxes from last year and update it for any expected changes. So your savings are really based on the income estimate for the year you want coverage for, not last year's. But if you expect to make the same amount of money this year as you did last year, then you can go ahead and just check your tax form for your adjusted gross income, because you have to put that on your taxes every time you fill that out. So that makes it a little bit easier. You can just refer to that line item, especially since a lot of folks do their taxes online nowadays. So it will tell you what you need to include. It'll tell you how to estimate the income, and they offer you an income calculator to help you make the best estimate you can in the easiest way possible. And it tells you who to include in your household and things like that too. And it also tells you whether or not there are people in your home who don't need coverage. It only takes like a minute to put in the information. It'll ask for your zip code first if you want to see the plans that are available to you. And you'll put in your zip code. Then it will ask you for those little bits of information I mentioned about your family, nothing real invasive. And then it's going to ask you if you want to go ahead and see your plan categories. And so when you click on that, it's going to show you categories of like bronze, silver, and gold. And so it's important to know that the categories are not supposed to be associated with care quality, that all of those plans are covering the same set of essential health benefits at the very least. So if it's in the bronze, it's going to be in the silver and the gold as well. It mostly has to do with the amount of your premium. So that's the amount you pay each month. So you might pay less per month on a bronze plan than a silver one, but your overall deductible is higher. So that means the amount that you have to pay out before your insurance plan starts paying for things is higher. And you'll probably also have a higher copay. So you'll pay more when you go to get care because you're not paying as much per month. Does that make sense? So I had an old insurance plan, and in it I had to spend $1,500 before they would pay out for it. So that includes prescriptions. That also included my doctor's visits, blood tests, x-rays, things like that. And after it paid out on those, or I paid those with coinsurance or with the premiums that year, then it would start paying out itself. Does that make sense? Okay. So that's kind of how that works. So you have your coinsurance, your copay when you go in, and then the deductible is the total amount for the year you have to pay before they start paying on it. And then your monthly amount is your premium. So that's mostly the difference, is how much these things cost per month versus how much your deductible and individual visits will be. So that's what you're looking for. So there are many different options out there. You have Blue Cross and Blue Shield of your specific state likely on there. Some other big ones are United Healthcare and Aetna and the Oscar Health Plan if you are in North Carolina, which is where I am. So there are a ton of different ones. Picking the best one for you partly depends on how much you want to pay for the deductible and how much you want to pay for your monthly amount. So a lot of folks who don't think that they're really going to need to go to the doctor unless it's like a catastrophic event will just get emergency gap insurance, where they will go ahead and get a plan where they have a low monthly rate and they'll just have a high deductible because they don't think that they're going to need to pay any more than a couple hundred that month, or that year, that it won't make sense for them to pay that much because they don't expect going to the doctor that much. So they might choose to pay like a $6,000 deductible because they think they're only going to the doctor like 3 times, and they'll probably have $100 copay, but they're also only having to pay $250 per month or so for their premium. And so that makes the most sense for those folks. Whereas other folks might need to go to the doctor a lot more. Say you have a chronic health condition, and so you need to go monthly for different treatments, or you have really expensive medication that is way cheaper with this insurance to help offset that cost. So in those cases, you might want to pay more per month and then have to pay a lower deductible, because in the long run during that year, it's going to be cheaper for you to do it that way, because you know that you're going to need, more than $7,000 in medication this year. So you're going to go ahead and pick that, because that's not even counting the treatments and everything else. So that's one reason why somebody might pick a lower deductible, but with a higher monthly premium, because you think that you're going to go more. Now, those rules aren't hard and fast. That's not necessarily going to be the case for everyone, and it is very much simplified as to how people's healthcare works and how human health works, really. There's so much more socioeconomically and culturally and biologically that goes into that it's too comprehensive for me to discuss all in a single episode. But I do want to go over the top health insurance companies with you guys, as well as some of the top choices. So first, what about the best health insurance companies? That really depends on what exactly you're looking for. So for best overall health insurance, that one is United Healthcare. That is the one that is rated the best in the industry on these main factors of having a great financial strength rating. So whether or not that company meets its obligations and pays out like it's supposed to. And that score also analyzes the financial health of that insurance company. Then you have the pricing. So you have these quotes for a sample policyholder who is 40 years old. And so they apply for the same policy for someone of the same demographics across the board, and that way they can compare them against each other based on just the prices and the things that are covered. And then they also do the Naic Complaint Index, the National Association of Insurance Commissioners Complaint Index, to find the number of complaints that a company has received, measure that against its size, so you have kind of a per capita measure, and then compare it to similar companies across the nation. So if the company you're looking at has a complaint index number under 1.00, that means the company receives fewer complaints than is expected for its size. So if it's under 1, then that means it's really good. If it's over 1, that means that they're getting more complaints than are expected for their size. So those are the variables that were used to measure who is the best health insurance company in this study. And they found that the best overall health insurance was UnitedHealthcare, but the best health insurance provider network was Blue Cross and Blue Shield. You have more options and better payouts with Blue Cross and Blue Shield for their provider network. So there are more people across the United States who accept Blue Cross and Blue Shield than perhaps for UnitedHealthcare. But that's not all that surprising, considering how Blue Cross and Blue Shield was born, now that we know that, right? So it was one of the oldest ones, and it also formed by physicians creating their own prepayment plans and insurance companies. So, of course, their network is going to be a lot bigger than United's. Then we have the best online health insurance, and that is Oscar. So if you're looking for online health insurance, Oscar might be your best bet. But if you're looking for the best Medicare Advantage, then you're going to want to go with Kaiser Permanente. That was the one that received the top score for the best Medicare Advantage. So don't take my word for it. Go out there and do some research yourself too and see what you really need for your coverage. You can look for their NAIC Complaint Indices as well, now that you know what those are. Oscar, for example, has one of 0.12, so that is well below that 1.00, and that's a pretty great complaint index. It means for the size of this company, there aren't that many people complaining about it. There's not even the expected average amount of complaints that they theoretically think should occur. So that's really good. Oscar is also unique because it offers doctor on-call services, and they have technology that allows you to track your policy. So they have a dedicated concierge service with 24/7 access to health professionals. The main downside to it is that it's really limited by the states that it offers its individual and small business health insurance policies. So Oscar isn't that expansive yet. It doesn't have the large network across the country that Blue Cross and Blue Shield, or even United to a lesser degree, has. So Oscar is a startup, and it plans to continue expanding the health insurance states that it can offer health insurance in, but right now it's still a little bit smaller. It does charge above average prices, but they have really great customer service and really good extra benefits for members. So it just depends on what you're looking for. When we're talking about Kaiser Permanente, it had an NAIC complaint index of 0.33, so that's also well below that 1.0, and it offers Medicare Advantage options. So that is available in many different states, but not as wide as Blue Cross and Blue Shield. It is known the best, though, for having many different Medicare Advantage policies, benefits. So it is really in-depth in Medicare Advantage policies. Blue Cross and Blue Shield had a 0.2 NAIC complaint index, so also very low, and they are the most expansive network available. So they have access to HMO groups, EPOs, so your health maintenance organizations, your exclusive provider organizations, and also PPOs, your preferred provider organizations. So you can opt into one of those different types. Blue Cross and Blue Shield is also available in every single state in the U.S., but many customers have complained about the product servicing and also coverage denials. So I would look into that a little bit, even if their complaint index is low. So it's somewhere between Kaiser Permanente and Oscar, but people were still complaining about those specific issues. And if that's something that would bother you, then check that out. Although, as someone who recently moved from Texas to North Carolina, I can tell you firsthand that having a provider network across the United States could be really helpful. I did not realize before I moved that my healthcare insurance was really tied directly to a specific hospital system or a community of hospitals. And so it only really worked in Texas. I wasn't able to really use the rest of my benefits where I was in North Carolina. I used to have United and Blue Cross and Blue Shield, so those were a lot easier to use. And, they have really broad networks. So it never even occurred to me that traveling to a different state within the same federal government would mean that my insurance wasn't really usable. But I might as well have been in, Italy, anywhere but here, for all the good that it did me. So keep an eye on that too. So if you're planning to move, you may want to go with one of the wider provider networks like Blue Cross and Blue Shield or United Healthcare. We also have United. So United is really unique in that it offers pretty high quality services within just an average size provider network. And they offer dental, vision, and health, but it depends on which state you're in, how limited or expansive that may be. So check it out for your specific state. A lot of United Healthcare policies are more expensive than average. I got my old one through my work, but the plans do come with some added benefits and often access to wellness programs. It's also really highly rated with customers, so the Naic Complaint Index for it is 0.00. So customers say that they have a really supportive customer service department, and their app on your smartphone is really user-friendly. They also have the largest health insurance company by total policy holders, not by the expansiveness of the network. So Blue Cross and Blue Shield is available in every state, whereas United Healthcare isn't, but more people are choosing United Healthcare overall. And they also offer health, dental, vision, and disability coverage. So getting all of your different types of insurance in one place can be easier with United Healthcare. And that's the unique value that it offers. So those are the top 4 companies, whether you're going for Medicare expanded coverage, so that Medicare Advantage coverage, or if you're going for United Healthcare versus Blue Cross and Blue Shield, or Oscar, or Kaiser Permanente. Those are the top 4 that were rated on those variables we discussed. And so that tells you more about which company you might want to choose. And when it comes to choosing a specific plan, remember just to take a look at what all is covered and then the differences in how much you would have to pay per month and per visit to the doctor versus per year for the deductible, and kind of weigh that against how frequently you need to go to the doctor and how much that tends to cost you per visit. Because even if you don't have many visits, if they are for big things, that might cost a little bit more money. So if you're offered these through your work, by all means, go to the office and ask your HR person about them. If you are not offered these through work, you can go to the marketplace and find the insurance online that's right for you. You can also just opt into these individually if you would like to. Blue Cross and Blue Shield and all these other insurance companies offer not just commercial insurance, but also private insurance to individuals. And the healthcare.gov website has been really helpful for me when I've just wanted to compare different policies, even if that's the one that's being offered through my company versus a bunch of others that I might want to pay for privately on my own. So you have options out there. There are ways to go about it and get it. And regardless of the origin or efficacy of United States health insurance, now you know the options and the facts surrounding them. Do with those what you will, and remember that the open enrollment period for insurance at healthcare.gov is between November 1st this year and December 15th. So make sure you opt into your 2021 coverage through the marketplace if that's the way you choose to go get it, by December 15th this year. Also, don't forget to vote. Thank you for listening to the GSMC Health and Wellness Podcast, brought to you by the GSMC Podcast Network. I'd like to ask that you please subscribe to the show, and writing a nice review always really helps us. Also, if you could please follow us on Facebook, Twitter, and Instagram, I'd appreciate it. Thank you kindly, and have a good night.
You've been listening to the Golden State Media Concepts Health and Wellness Podcast, part of the Golden State Media Concepts Podcast Network. You can find this show and others like it at www.gsmcpodcast.com. Download our podcast on iTunes, Stitcher, SoundCloud, and Google Play. Just type in GSMC to find all the shows from the Golden State Media Concepts Podcast Network, from movies to music, from sports to entertainment, and even weird news. You can also follow us on Twitter and on Facebook. Thank you, and we hope you have enjoyed today's program.